Mingla Sierra Guru Chain Baby or the webinar day out there in the Jesuit Timare. Sarah in a let Nego Lolo Tare drop in manager. General Sierra Chuletima, Janitin Tuama, College of GPR, Mapi, Tawangama. The webinar General Lao, Naka, Lupare, the car General College of Physicians, Le Palmio, Lote, College of Physicians, consultant hematologist, Dr Zor Thin Maung, the webinar, in Sepame. Dr. Zor Thin Maung, so can you introduce yourself, please?
Thank you. Jesu Demare, Alo Minglava, Patamazo no, the Myanmar Association of General Practitioners, ne Royal College of General Practitioners, go Jesu Demare, the low season period. Now, Biro Kulo to Ningrini, Yaubaima, or Dugudiga, join Lote, see Sia Wuniule, or Jesu Demare, or welcome my Josubare. General Zor Thin Maung, UKR hematologist, Dine Biome topic or webinar, the understanding the full blood count. So the topic are again very basic, but again really so full blood count, very familiar. How to make things easier in daily life through using the full blood count. Now, full blood count, UK full blood count, correct? You know, blood for CP complete picture, low correct. So the session webinar objectives are number one are to understand the important parameters of full blood count. The full blood count so there are so many the measurements for hemoglobin red cell parameters such as MCV or red cell count, hematocrit, now white cell count, platelet count, and my Beharia so emphasize low now at the end of the session, solution the day out there is the should be able to interpret the full blood count abnormalities, the results, common diseases, the common conditions, able to identify and interpret now the full blood count results below clinical decision so investigate or management or hematologist refer so as you know, primary care general practitioners every day in and out the result so full blood count below health now full blood count most commonly requested laboratory tests. Solution or anybody name account lose full blood count now patients with the bleeding now infection now pregnancy, now preoperative assessment now drug treatment solution full blood count baseline and then monitoring of the treatment so full blood count it is very widely used so full blood count solution clinical sign rather than a laboratory investigation because and then you can work it out. So patient go to the full blood count result so clinical decision the health screen health screen in full blood count check ဒါပေမဲ့အဲ့ဒါကိုတော့ encourage မလုပ်ပါဘူးဘာလို့လဲဆိုတော့ patient က symptom မရှိဘူး patient ကနေကောင်းနေဆိုလို့ရှိရင် full blood count လုပ်တာအဓိကတော့ဘာမှ it will give ဟလာဟို results တွေ outcome တွေဘာမှပြီးမှမဟုတ်ဘူးအလကားပဲ resource တွေ waste လုပ်ရပဲကြားတယ်ဆိုတော့ normal common health screen အတွက်ကတော့ recommend ဒီမလုပ်ပါဘူးဒီ UK မှာလည်းမလုပ်ပါဘူး now full blood count မှာဆိုလို့ရှိရင်တော့လွယ်ပါတယ်ဒီအများလေးသိကြမှာပါဒီ venous blood ကိုယူဖောက်ပြီးတော့ဒီ EDTA ဒီ anticoagulant ပါတဲ့ကျုပ်ထဲကိုထည့်ပြီးတော့ laboratory ပို့လိုက်ရင် laboratory က it's an automated ဟလာအဲဒီ instrument က full blood count တွေကိုဆိုလို့ရှိရင်အများကြီး read လုပ်သွားတယ်ဆိုလို့ရှိရင်ဒီ throughput ကတနေ့တစ်နေ့ကိုဆိုလို့ရှိရင်100 to 1000 sort of the machine is able to analyze the samples and give the results. Now, depending on the urgency, the results they are solution is once the machine will out the solution within 15 minutes solution results ya yanai mare. So a clinical urgency she the results you memnya tongnai mare. Every koa solution patient where say pure banya solution you can always contact the laboratory and ask for an urgent result. Now, full blood count, like this one, 3 sample lab go like this one. He's got form of a request form. Now, the option are Dimaro solution online body, request like the online cheat or paper form, paper form, the information are imitant Pari solution name pame, a gender, la male, female, now date of birth, so that the laboratory advisement period, the information sheet you can get a proper advice. Now, the patient identification number, now Payani Pudeles, GP surgery, which surgery address, clinician, like the GP's name. Now, contact details, results abnormal in laboratory can be contact urgency, solution contact details, telephone number, email, now urgent la, routine la. Now, a chamber, 3 powder now to clinical details for bar full blood count powder less Example, solution, for example, patient solution, date of birth, patient identification number, say inpatient solution or say number body, GP solution or number, or solution now Bayani la the ward or GP surgery, Bayani la clinician, la the test request load the clinician name. Now, contact details are results are very abnormal solution in laboratory or hematology department are contact details are or urgent la, routine la. So urgent solution or DMA solution or within 3 to 4 hours results are or routine solution or maneka pauline results are dame. There might be a solution of primary care banyas or results got blue lare or side lare banyas, no now to need to shana in a body. Now it's a chain, a lot powder near, powder chain, because results got within 24 hours, analyze local. Now the clinical details, for example, dietness, weight loss, or splenomegaly, result or information or people.
Yeah, screen share building. Screen share. So, yeah, screen share. Oh, yeah.
I'll do it again. Yeah. Screen share. Paula,
yeah.
Okay. So, kuna sort of request form, name, gender, date of birth, patient identification, the origin of the sample, clinician, urgent la, routine la, date and time, and clinical details. Clinical details are tiredness, weight loss, splenomegaly, anything. It is very helpful to the hematology. So information results are solution there. You get a more important result can be generated. Now, full blood count solution results here. I'm sure you are familiar. So results here: hemoglobin, red cell count, hematocrit, mean cell volume, so MCH, mean cell hemoglobin, mean cell hemoglobin concentration, white cell count, differential white cell count, platelet count, blood film. So so every day, day-to-day patient the result it takes a lot of time. So there are 4 parameters. Solution, guidance page. Hemoglobin okay. Hemoglobin, whether patient anemia anemia now to MCV, mean cell volume. I'll tell you if the patient got anemia solution, what type of anemia. So you can forget the other red cell count or hematocrit to MCH to MCH0. Forget the solution or the training body, even the hematology training solution. We train only to give hemoglobin and MCV. You can forget the others. Okay. Now to go white cell count body. Will tell you whether white cell count is increased or decreased. If the white cell count is abnormal, solution or neutrophil count, now to the platelet count. So at the moment, if you first start to interpret or look at the result, try to look at these 4 first, okay, and then you can work it out. You can interpret a lot just by looking at these 4. So the normal values you can sort of interpret. So case study lady. 65-year-old woman body, so tiredness, 3-month history of tiredness. So the patient are GP surgery or so surgery or diet solution of body, anemia so the result of okay. Have a look at these results and see what the results got solution. Hello, so hemoglobin hemoglobin 77. So the patient is anemic. That's why the patient are diet. So the next step, look at the MCV. So MCV 67. So MCV low MCV. So this patient are microcytic anemia. So white cell count are normal. Platelet count are normal. 400 nearly 10 body platelet. So most significant result are hemoglobin and MCV. So I'm sure you all are familiar with this. So the diagnosis will be iron deficiency, anemia, most likely. Solution or laboratory result commonly. A carry common result solution. So GPT the result interpret solution. You can make a diagnosis from it now because the patient is anemic and there is low MCV, so microcytic anemia, and most likely is iron deficiency anemia. Since there are other causes, the child causes of microcytic anemia. Those tiredness and mutiny solution. The child causes it is less likely, most likely iron deficiency. Because iron deficiency, anemia is a very important condition, especially in postmenopausal women and or men body. or postmenopausal iron deficiency solution. Conditions so it looks like iron deficiency. Below confirm low solution. Serum ferritin or low lipo, low solution. Ferritin also low so iron deficiency. Eddie Kama solution since I'm a parcel postmenopausal women, or men or adult men, iron deficiency anemia solution. The most likely cause is blood loss. That solution since I will GP referral or GI referral local endoscopy local so since I'm similar results there. Tiredness for 3 months. Solution or imagine results hemoglobin 90 gram MCV is low. So white cell normal, platelets normal. Again, that solution iron deficiency anemia is the most common thing. I mean, DUMR solution or ferritin check low body. I mean, GI studies here or solution recommend most common anemia is due to menorrhagia or pregnancy or other causes, usually only after midlife. I think I say GI blood loss as the underlying cancer. So there's a little causes of iron deficiency since I'm a body. Children and adolescents in solution or dietary are common. Developing countries like Myanmar, still helminthic infection is the common cause of iron deficiency. Anemia, so are the most common cause body. Dietary deficiency and helminthic infections. So young women previous scenario solution or menstrual blood loss or pregnancy, but some young women have some dietary the restrictions that could be the cause. Again, helminthic infection can be a cause. The UK Maro, helminthic infection, so the chart condition since iron malabsorption, celiac disease, so inflammatory bowel disease like ulcerative colitis or Crohn's disease, so since men body and postmenopausal women solution or GI blood loss is the common cause of iron deficiency, especially due to cancer. That's how men and postmenopausal women solution always have to consider underlying gastrointestinal blood loss, whether you should refer the patient to gastroenterologist. Helminthic infection is less common in men and postmenopausal women, and malabsorption, inflammatory bowel disease are other causes. So the causes depending on the likely causes, you can plan the further investigations. For example, if you suspected iron deficiency, you confirm by iron studies. So the or serum ferritin or serum ferritin iron deficiency be the solution, clinically assessment report. Are there any major clinical clues? History, clinical examination, for example, mutiny and history of menorrhagia, diet, solution, or I think this is yes, iron deficiency is most likely to be menorrhagia. You don't need any other investigations to replace the iron and treat the menorrhagia. Of underlying gastrointestinal condition, solution arrange upper GI endoscopy, gastroscopy, and colonoscopy, and screen for celiac disease. Significant GI pathology to solution or treat as appropriate, CA colon to solution surgery or gastrectomy, depending on the underlying cause, treat low. So if irreversible solution, treat solution, you have to consider long-term iron treatment. Since I would do it. Okay, Barcos mama to solution or now to set the coup, set investigate low or small bowel disease, or you need to refer to gastroenterologist or abnormality to so treat low solution or some people have the long-term iron deficiency problems. Continue long-term iron replacement therapy. So this is the algorithm. Dima, sort of the British Society for Gastroenterology, I recommend look at algorithm. Since I'm a police, so I health infection so since I will. Now, this is another sort of the scenario. This is the 25-year-old woman, so 12 weeks pregnant, and this is the first pregnancy. So full blood count look there. Demasolution, every pregnant woman, when they come to first booking, they have a full blood count. So like stick to hemoglobin and MCV and white cell and platelets. So hemoglobin are nearly or it could be, you can call it as normal. I mean MCV are so white cell count are normal, platelet count are normal. So you have to think, commonest cause of iron deficiency, but even hemoglobin is normal. Iron deficiency is quite common in pregnancy in young women. So that's in Zame. Now to Kusinzama, to the Southeast Asia solution, hemoglobinopathy, thalassemia, so quite prevalent. So that is another possibility. So or hemoglobinopathy or thalassemia or hemoglobin E or carrier is most likely, plus or minus iron deficiency. So now hemoglobinopathy, so this scenario so red cell count got raised, increased, whereas in iron deficiency, the red cell count is lower than normal. So that sort of so looks like hemoglobinopathy. But again, iron deficiency cannot be excluded. Demasolution or serum ferritin check low man. Now to Kuaro, hemoglobinopathy screen. So we call it high performance liquid chromatography, HPLC, or you can do hemoglobin electrophoresis, whichever is possible. I think you should do both because in pregnancy, we can't wait for the results. So we can't wait for the investigations to be done later. So this is the investigative. So both ferritin, sort of the HPLC, hemoglobin electrophoresis will check both then. Now, this is another scenario. This is a 65-year-old woman, so complains with pins and needles, so pins and needles. So, and like that, again, hemoglobin patient anemic. So the next step will be MCV. MCV or MCV, it is significantly raised. And the white cell count so nearly chani, and the platelet count nearly chani. So blood films got macrocytes poly. So this means macrocytic anemia, red cells are bigger than normal. Macrocytes is here, or blood film are hypersegmented. That solution or the most likely diagnosis got vitamin B12 and folate deficiency. I think I think folate deficiency is quite common. B12 deficiency led to Dimaro B12 deficiency or UK solution of the road to so the amyo picture to anemia she MCV 10 years solution number 1 arrow B12 folate will check low light. If you get the results, then you treat. So blood film solution red cells low. They are bigger than normal. This is a sort of the normal size, so bigger than normals. And through the neutrophil solution, segments, yeah, you normally sort of 3 to 5 segments, where she in the megaloblastic anemia, B12 folate deficiency, nucleus segments, yes, about more than 5 to yare. That's about it. So that means hypersegmented neutrophils. So if you see somebody, patient out here, full blood count pouty lilo, MCV 10 solution, there are only a few causes, so you can work it out. Common things are 1 arrow deficiency, important to exclude, so B12 and folate deficiency. Now to go arrow hemolysis, like hemolytic anemia solution, reticulocytes are increased here. And the reticulocytes that they're young RBCs, they are bigger than normal. The MCV is big, higher than normal erythrocytes. Through MCV are dead. Another cause of liver disease, patients with liver disease, they can have high MCV, and some drugs can cause high MCV. And I remember solution of primary bone marrow disease since I would have. So B12 folate deficiency solution could not be MCV at any cytopenia, blood film could not oval macrocytes and hypersegmented neutrophils. History pins and needles, neuropathy, diarrhea, malnutrition. It's quite easy. You just do serum B12 and folate levels, and you can make a diagnosis. You can work it out from there. If the serum B12 and folate are normal, think of other causes. So hemolysis. So hemolysis solution or hemoglobin patient solution jaundice, the chart signs of hemolysis so reticulocyte count will be increased. You can ask, do the next test as a reticulocyte count. Now, liver disease or history, alcohol history, whereas hepatitis B, hepatitis C, history. Drug-induced, I think methotrexate rheumatoid arthritis solution, they can get high raise MCV. Drug history, liver disease, there are no signs of hemolysis. B12 and folate normal solution, or since our primary bone marrow condition or primary bone marrow disease, so known as myelodysplasia, so LR solution, or you refer to hematology. Myelodysplasia, solution. Previous, chemotherapy, now blood film solution, dysplastic neutrophils that they look very abnormal, or blasts, or leukemia type cells. So this algorithm, I gave somebody the macrocytic anemia solution. Always B12 folate check low normal solution, exclude hemolysis, bilirubin check low, reticulocyte count check low. Normal solution, exclude liver disease, history, examination, history of. Then you should try to see whether liver functions are normal, check the liver function test. Now to go a drug history review local. Still anemia unexplained to the solution, or the patient will need a bone marrow examination to refer to hematologist. Or the blood film shows cytopenias, and if it shows dysplastic neutrophils or blasts, then you refer it to hematologist. So this is another scenario. So 55-year-old woman with history of tiredness for 3 months. So again, for anemic, hemoglobin only 85. MCV is slightly raised, 103. Then white cell count is slightly reduced, and the platelet count is reduced. But on the blood film, pseudopelvis cells, I will show you, that is abnormal dysplastic neutrophils. Or you got hypochromic neutrophils here. They appear hypochromic, so granules here are very faint. Or the blast, that's the most important thing. If they are blasts on the blood film, then you refer the patient to hematologist. So hematologist will do a bone marrow to make a diagnosis. But so I will do B12 folate this patient, then look for any liver disease, or there is no evidence of hemolysis. So drug history, and blood film, it shows the blast, right? So no bone marrow disease resolution refer. This is the abnormal neutrophils. Neutrophils are normally solution granules. Granules are very faint granules. And normally they are 3 to 5 lobes, but only 2 lobes here. So the abnormal neutrophils here solution. Most likely is a myelodysplasia, so refer to hematologist. There's another condition. This is quite common. This one is common in the general practice. A 68-year-old man with a history of diabetes and hypertension and complaints of tiredness. So tiredness or GPR surgery method. So results are so how would you interpret so by condition you sinzamle? Solution could not build the hemoglobin no level, hemoglobin patient is anemia, then MCV normal, or maybe it could be slightly low normal or normal, but it's not very low, it's not increased, but normal or it could be low normal. White cell count is normal, platelet count is normal. So so this is what we call normochromic normocytic anemia, because size of the red cells are normal. So normochromic normocytic anemia. And so commonest cause, somebody who's 68, history of diabetes, hypertension. So so CKD is one of the common causes of normochromic normocytic anemia. So if you've got normochromic normocytic anemia, always think of CKD as an underlying cause. So EGFR or creatinine, you got the results there. So this patient has got very end stage or advanced CKD. So that is the cause of anemia. So which is very important. Does normochromic normocytic anemia history resolution think of CKD as the cause of anemia. So normochromic normocytic anemia is CKD. There's another type of normochromic normocytic anemia. We call it anemia of chronic disease. So anemia is due to some underlying sort of the chronic condition or inflammatory condition. For example, patients with the rheumatoid arthritis, patients with chronic infection like chronic osteomyelitis, or patients some cancers, and they can develop anemia of chronic disease, especially kidney cancers. No, the solution, MCV are normal or reduced, white cell count normal or maybe increase. So platelets again normal or increase. But the important thing is, I don't know, the investigation. ESR or CRP, usually they have very raised ESR, raised CRP, and the blood film may show some rouleau formation of the red cells, which as an indication of raised ESR and CRP. So then you have a normochromic normocytic anemia, sort of the anemia of chronic disease, will consider a logo. Now mixed caro, anemia at Kumo, for example, somebody with the iron deficiency anemia may have chronic kidney disease. So you can have all sorts of mixed thing. Anemia solution, even if the MCV is normal, it is worth checking the serum ferritin as well. If you can't find anything solution, then talk to the hematologist. So it could be the primary hematological condition. So this is another algorithm, normochromic normocytic anemia. So check the renal function, like EGFR or creatinine, and ESR would be worth doing it. If it's very high, think of anemia of chronic disease. You still should check some hematinics because there could be some mix. So a deficiency anemia can be mixed with renal failure or anemia of chronic disease. And think of underlying malignancy, such as kidney disease, lung cancer. Anemia is still unexplained solution, or talk to hematology. Or if the blood film shows leukemias or some abnormal features, then think of the bone marrow disease as an underlying cause, and then sort of talk to the hematologist. So there's another scenario here. So 68-year-old man with a history of weight loss, and then headaches and jaw pain. So weight loss, headaches, jaw pain. So သွေးဖောက်လိုက်တော့ so hemoglobin ကျနေတယ်။ဒါပေမဲ့ MCV ကတော့ normal ပဲ white cell count နည်းနည်းလေးတက်နေတယ် platelet count နည်းနည်းတက်နေတယ် so something is not right. So this is most likely to be anemia of chronic disease, especially with the jaw pain and headaches and weight loss. So most likely to be polymyalgia or giant cell arteritis. This is a typical hematological picture you see in giant cell arteritis. So by test low neck or ESR or CRP low level, then sort of the flow solution or temporal artery biopsy or solution, as you can give a trial of steroids in this condition. So this patient, eGFR is only slightly reduced, so it can't be, so CKD can't be the cause of anemia, but the ESI is very high, so it must be. So with these symptoms, it's most likely to be giant cell arteritis. Now, your blood counts, this is another scenario. This is a 55-year-old woman with COPD, has chronic obstructive pulmonary disease, and so smoker, so her blood low light or hemoglobin anemia or the other increase in the hemoglobin. So this is known as, we call it polycythemia. Polycythemia are, I think, the patient MCV are normal there, white cell count are nearly 10. So since I'm a body, hemoglobin is in body Chinai one hour smoker, that COPD solution, they tend to be hypoxic, and that can cause a secondary polycythemia. Or it could be the hypoxia causing the secondary polycythemia or primary polycythemia fever. So think about it. So it's not only anemia. If you look at the full blood count, hemoglobin or GBO, hemoglobin is solution body another sort of the scenario, a 38-year-old man with a fever and pleuritic chest pain gets it. So MCV normal there. Cell count white cell count is raised for leukocytosis. And if the white cell count is raised, then look for the differential then. So neutrophil count is raised, and neutrophilia, the platelet count is raised. So it looks like this is a typical feature you see in pneumonia, community-acquired pneumonia, where you get bacterial pneumonia, where you got the white cell count is raised, and neutrophil count is raised. Now, platelet count is also raised in sort of the acute inflammatory condition. So that's why you have a raised platelet count in this condition. So neutrophilia with reactive thrombocytosis, so compatible with acute pneumonia. So you would make a decision, or the patient is quite sort of the ill patient got systemic illness, inflammation and pneumonia. So you will start the antibiotics, or the patient may even require sort of the referral to the emergency department, depending on the condition. So that's a neutrophilia. Neutrophilia, commonest cause of bacterial infection. Another cause is the active inflammatory disease, like inflammatory bowel disease. And you can have the neutrophilia. Steroid therapy is another cause of neutrophilia. And so sometimes you do a blood test on a sort of the end, all of a sudden, an unexpected sort of the result neutrophilia, then you have to work it out. So then you, patient a drug history, which you like steroid therapies, then you think of, that might be the cause of neutrophilia. Now, post-op patients, especially post-bowel surgery, post-op patients, they are neutrophilia because of the tissue necrosis. The other rare causes are systemic autoimmune diseases such as vasculitis or cancer. Inflammatory bowel disease, or active inflammatory disease, steroid therapy, these are commonly seen in general practice. The other thing is the smoking. People who smoke, sometimes if you can't find the cause of neutrophilia, cause smoking. People who smoke, they tend to have the raise of the neutrophil count. And the other very high neutrophil count can be seen in conditions like chronic myeloid leukemia, but this is very, very rare. For example, this is a 55-year-old woman with the splenomegaly. Spleen is about 10 centimeter. Solution, our blood called Paulito, hemoglobin is normal, our MCV normal, but the white cell count is increased. And the white cell count is mainly the neutrophils. So it could be neutrophilia, but she does not have any features of acute inflammation like pneumonia or acute bacterial infection by a machine. So then you think about, or could it be due to underlying bone marrow condition called chronic myeloid leukemia, and the blood film tell you there are many myelocytes or some blasts are present. So you work it out. So you have to work it out, not only on the results that you get from the clinical history and the findings. Somebody with a spleen 10 centimeter and with this sort of full blood count or CBC result, I think the diagnosis is most likely to be chronic myeloid leukemia. Then you refer the patient to a hematologist. So appearance compatible with chronic myeloid leukemia, so it's sent to hematologist. Now, likewise, you can get a neutropenia. Neutrophil count is, if the neutrophil count is less than 1.5, you call it neutropenia. So most common cause for drug-induced, always check the patient's drug history when you see neutropenia. Other causes are autoimmune diseases, SLE, so rheumatoid. Sometimes sepsis can cause neutropenia. And the liver disease, portal hypertension can cause neutropenia. Now, whether it is due to primary bone marrow disease. Another cause, ethnic, people who come from Africa, like Africans, or some Middle East, so the Arab sort of the descent, they tend to, their normal neutrophil count is less than 1, so they tend to be neutropenic. So don't get alarmed. So if the patient is from this sort of the ethnicity, solution or refer to hematology, it could be idiopathic. So drug history is very important. I'll come to another scenario, which is a 25-year-old woman with a history of menorrhagia and skin bruising. So hemoglobin is normal, MCV is normal, white cell count is normal, differential count is also normal. Platelets is only 6. So what are the likely causes? Since our thrombocyte blood film or thrombocytopenia, so you have to think of it. So hemoglobin are normal, white cell count are normal, platelet count reduced, so only platelet count is reduced, and blood film shows no abnormalities. So primary bone marrow disease is less likely, but it is more likely to be sort of we call it autoimmune thrombocytopenic purpura, or ITP, ITP is a likely cause. Another likely cause is whether this is due to disseminated intravascular coagulation or DIC, which could cause the thrombocytopenia alone. So check the isolated thrombocytopenia. That's why to exclude DIC, if you see thrombocytopenia, so check the coagulation screen. Because DIC association platelets go on blood film, sometimes you can see the fragmented red cells, and history examination, sepsis or infection will be seen, and you check with the coagulation screen, which will show the abnormal or prolonged prothrombin time. So APT will be prolonged as well, fibrinogen will be reduced. So liver disease can cause thrombocytopenia. So liver disease, white cell count will be reduced, MCV will be increased, and the blood film will show some target cells, and the history examination by alcohol history, hepatitis, jaundice, ascites, carcinoma. The cause of thrombocytopenia is most likely to be due to liver. Bone marrow solution normally see splenomegaly or lymphadenopathy, and the blood film will show abnormalities. Para solution of bone marrow referred to hematology. If the blood film shows no abnormality and there is no splenomegaly, no lymphadenopathy, no evidence of liver disease, coagulation screen is normal, then you think of ITP, autoimmune thrombocytopenia. So hello, you have to work it out like that. So blood film and coagulation screen are important. So the algorithm is thrombocytopenia, check coagulation, and you can check because sometimes folate deficiency can look for liver disease and sort of the ask for blood film. And still thrombocytopenia is unexplained solution or can talk to the hematology. The patient may need a bone marrow examination. This is another scenario, same 25-year-old woman, menorrhagia and skin bruising, but this time the patient is anemic, MCV is normal, normochromic, normocytic anemia, white count is reduced, and platelet count is reduced. So it looks like it's not only thrombocytopenia, the patient's got anemia, neutropenia, thrombocytopenia, and the blood film will show some occasional blast cell. So this fits with acute leukemia. That is the urgent, you must ring immediately to the hematologist for urgent admission and treatment. So you can work it out like the difference thrombocytopenia from the full blood count. You can work it out whether this is likely to be ITP or this is likely to be bone marrow disease like acute leukemia. So severe thrombocytopenia with pancytopenia, check coagulation screen still should be checked, and this patient needs urgent bone marrow examination. This is again the scenario we discussed earlier, 6-8-year-old man with those headaches, no pain, so anemic, normochromic, normocytic anemia, white cell count slightly raised, platelet count is increased. Just want to emphasize, this is anemia, normochromic, normocytic anemia, anemia of chronic disease, like in giant cell arteritis. But what I like to emphasize is, in acute inflammatory conditions, the platelet count can be raised. So normal, sort of the routine, sort of the EGFR is normal, and so ESI is raised, so giant cell arteritis. So thrombocytosis, if the platelet count is raised, the commonest cause are reactive. So inflammation, so ESR-CRP is quite useful, yes? Or look for any evidence of active bleeding, they can have thrombocytosis. Patients with menorrhagia, they can present with thrombocytosis. Another cause of unexplained thrombocytosis is iron deficiency. We've very commonly seen that. If you have excluded these, if you see thrombocytosis, think about rare underlying bone marrow diseases like myeloproliferative neoplasm. So this is very rare. I think if you remember, thrombocytosis is a feature of inflammation or bleeding or iron deficiency. That will be sort of pretty good in your daily practice. So conclusions, so full blood count has become a clinical sign rather than a laboratory test, because you can make a lot of diagnoses by history, examination, and full blood count. So abnormalities in the full blood count is informative in all fields of medicine. It's not only medicine, it's in obs and gynae, surgery, rheumatology. It is, you can certainly send referred to from the full blood count results. A schematic interpretation of full blood count is vital. So scheme hemoglobin, MCV, white cell platelets. So hello scheme here solution. I think it's much easier if you're going to look at all the results of full blood count. Sometimes now anemia is a common finding in medical patients. So assessment of the full blood count cause of anemia is essential in patient management. And it is important to recognize common reactive full blood count, reactive changes by 2 areas. So anemia, 29A, MCV may be low or maybe normal, and they can have the raised white cell count, and they can have the raised platelet count, and their ESR-CRP will be increased. So even if you have tried all these, but if there are persisting abnormalities, then discuss with a hematologist. That's the advice. So, I hope you find it quite sort of the good fun looking at the scenario, and I'm quite happy to answer any questions. Thank you. Oh, okay, I'll have a look. Yeah. Oh. A lot about the pool, right? Okay, screen. Okay. IDA versus thalassemia, how can we know? Role of MCHC. I think MCHCRO, I think MCV is good enough. If you want to learn another, if you want to memorize and learn how to interpret another parameter, you can learn MCHC. But I think MCV is good enough. Okay, MCV will be reduced in both conditions. I think I would do both. Okay, so just do it, because otherwise, this is both are very common conditions. They can go. I don't know how easy to do hemoglobinopathy screen. I think these days, I think they're getting more accessible. I think just do both. Just don't work on the eye. Some people look at the RDW and sort of thing, but you can look at it. The red cell count is increased in thalassemia, whereas red cell count is reduced in iron deficiency. But again, sometimes they are very common conditions. They can exist together. So I would recommend both to check. Ferritin versus CRP first. Again, I think white cell count is pretty good. Okay, I wouldn't recommend ferritin in bacterial infection because it will be raised, but it's very non-specific. You can do the CRP if you suspect infection, but clinically, if you got somebody who's got acute inflammation, sepsis, and the white cell count is raised, I don't think you even need a CRP. Okay, use your clinical sort of the acumen and sort of the very basic tests. How can we know cause of anemia in CKD or mix? Again, I think CKD is quite challenging, normochromic, normocytic anemia, and so sometimes they develop iron deficiency as well. So you can check the ESR-CRP, which will be raised. You can check the ferritin, but ferritin is not very reliable because ferritin can be raised. So it can be falsely normal in sort of CKD or anemia of chronic disease. But I think the British Society of Renal Physicians, they recommend that if you check the ferritin, if the ferritin is less than 100, you treat as the iron deficiency plus anemia of the CKD. So this is very difficult. There are more new tests are available, such as reticulocyte counts and things. But again, I think that is not, even in UK, not widely available. I think this is a lot you have to consider. Sometimes you might, because somebody with a CKD and the serum ferritin is less than 100, you should try a trial of iron and see whether that could improve. So this is quite a difficult area. Role of blood film, does every time require? Blood film is not required every time. UK MARA blood film is you do not have to request blood film. Usually the laboratory decide when blood film should be done. But if you don't get any sort of if you get results only the full blood count, if you still can't work it out, but there are some abnormalities, then you should ask for a blood film. Okay, if you see some abnormality, iron deficiency, I don't think you will want a blood film, but some other condition, if there are still abnormalities and you still cannot work out, you should request the blood film, but not every case, not every time they need a blood film. IgA with raised platelet can indicate some malignancy. Yeah. Yes, iron deficiency anemia itself can cause raised platelet count. So if you got somebody with iron deficiency, raised platelet count, I think take it as an iron deficiency. But again, iron deficiency, then you consider what is the cause of iron deficiency. Then you would say somebody who's a postmenopausal woman, somebody sort of men, adult men, you think of underlying malignancy, then you should consider that. So I think iron deficiency alone, raised platelets, yes, iron deficiency, that's it. But again, don't stop there. You think of underlying cause of iron deficiency, which could be cancer. Right, I always get this question, what hematology book and CBC book good for internists? That's a very difficult thing because CBC is, I think you try to interpret and then you take it from there, because I found no specific book for CBC interpretation. I don't know whether you have those in Myanmar. Dimaro CBC is everyday tests. You do the test, you try to interpret, and you learn from that. So hematology books, they are very advanced. Some of them are very thick and very big. So it is quite difficult. But I think if you follow, you will have these slides, follow the algorithm. I think that probably will help. For example, if you got somebody with macrocytosis or macrocytic anemia, what would you do? You would do B12 folate, exclude hemolysis, liver disease. So I think that probably will be helpful, because honestly, there is no sort of the textbook specific for CBC and sort of in hematology. It's a daily sort of, you learn sort of the on the job, sort of the learning and practice. Want to measure B12, is it good random or fasting? B12 can be done random, that's okay. Tissue B12 or serum, Dimaro serum B12, look at a Shabama Malabu. So I think serum B12 is enough. Don't think of any other things like tissue B12, okay? And you don't need to fast for B12. In APO due to AMI patient, said 20 easy when normal, could it be glucose due to stress? Yes, leukocytosis can be secondary to acute tissue injury. I think I show on the slide. Sometimes you see that in acute myocardial infarction. So some you can see the leukocytosis, but not as common as the other inflammatory conditions or infection, but you could see that. So yes, you're right. Yes, iron CRP may be normal. It could be due to acute tissue necrosis. May I know rule of NLR in infection? Can I just ask what NLR is? Anybody? NLR?
Intel, Bolembi.
Neutrophil leukocyte ratio.
Okay, neutrophil leukocyte ratio. I think you mean the percentage of the differential count. For example, you count 100 white cells, and how many percent is the neutrophil? I think that's what it is, NLR, neutrophil leukocyte ratio. I think full blood count results are now come as the automated results only, mainly. So we don't do the neutrophil leukocyte ratios anymore. I think if you do the postgraduate exams here, they all come in absolute value. So we don't now look at the NLR, but NLR is normally will be raised, but we don't use this parameter anymore. So if you got the absolute result, just stick on the absolute result. Rule of retic heme, yes, that's the one. reticulocyte hemoglobin is the one in anemia when you're not sure whether this is anemia of chronic disease with iron deficiency. When you're not sure, you can do the reticulocyte hemoglobin, but again, has not been universally available. If you have a machine which can do this, that is fine. But even in UK, I think this is not available in every hospital. So I think it is a good test. If you can use it, it will tell you whether there is an element of iron deficiency in anemia of chronic disease, for example, in CKD patients, whether there is an iron deficiency. It could be helpful, but again, I think still it is not widely available or used. But if it's available, you try to use it, but it's quite a bit difficult to interpret as well. Okay. Is iron studies should be done together or only ferritin, pros and cons? I think I would do mainly ferritin. I will forget my practice, or in UK, the other iron parameters, which are not helpful at all. Okay, so just do ferritin. If the ferritin is low, it's a bingo, it's iron deficiency. If the ferritin is normal, then you have to consider whether it is due to coexisting inflammation or CKD or anything like that. But ferritin, the other iron studies like serum iron, total iron binding capacity, they vary a lot, and it's very difficult to interpret. Even in this hematologist in UK, we always scratch our heads how to interpret that. It is not always easy. So if you can do ferritin, I would stick to ferritin. Difference between MCH and MCHC during interpretation. I think my advice is you can forget MCH, forget MCHC, don't even look at it. Just stick on MCV, because I think you've got enough. You've got so many things to look at and do. In UK, if we teach the medical students, we don't teach the MCH and MCHC. And even in hematology, the FRC path candidates, they don't know MCH and MCHC. It might be useful in some of the thalassemias and things, but I think if you stick to MCV, I think then try to get into full blood count interpretation. I think that's pretty good. You will learn a lot. Then you can, once you become sort of quite familiar with this, then you can think about MCH and MCHC. But if you stick with MCV, normally, I think you will be able to get to most of the problems. The histogram. The histogram is, again, I don't think clinicians here or GPs here are given histograms. They are used mainly in the laboratory for the quality control of the laboratory test. So the clinicians, they do not need to know the histogram of the blood counts. Just stick to the results. That's my advice. Rule of thrombocytopenia in elderly, further workup. Yes, thrombocytopenia in elderly is likely to be, you should investigate, because it could be due to underlying blood or bone marrow disease, or it could be something else. So I think, please do not ignore thrombocytopenia in elderly. Treat as the same as the other adult patients. Red hemoglobin standard in ACD, yes, that's the same question. If you can do it, you can do it, but I think the interpretation is difficult and is still not widely available. Does viral cause lymphocytopenia or cytosis? It can cause either, but commonly acute viral infections. Acute infection can cause lymphocytosis, but subsequently, if it's a chronic infection, it can cause lymphopenia. But if you think, like, for example, cytomegalovirus or Epstein-Barr virus or HIV acute, so you can have the lymphocytosis, but later on, they can develop lymphopenia. So more commonly, it's a lymphocytosis. How long is CP reliable for one patient? Reliable means the result of the tests. I think normally if the clinical condition doesn't change, I think it is reliable for a certain time. But if the clinical condition changes after you test, probably it's not that reliable. Or I don't know whether you're asking how long the result, you can keep the sample before analysis. Usually it has to be analyzed within 24 hours. If MCH is low, how can we interpret other results are within normal limits? If others are normal, MCH, don't worry about it. Okay. Why IDA alone can cause thrombocytosis? I think that's one of the causes of the thrombocytosis. When there is an iron deficiency, I do not know, but I think iron deficiency usually is associated with some acute inflammatory sort of the conditions or markers that could cause thrombocytosis. Sometimes iron deficiency is due to blood loss. That can be the cause of thrombocytosis, but it is very commonly seen. CHR, reticulocyte hemoglobin, increasingly useful in assessing anemia. Are you using it widely? I've answered no, we are not using it widely yet. What hematology book for internists? I think there is a book called Lecture Notes on Hematology. I think that is pretty good, but even then, I think it is very much detailed. So for the internists, I think probably there's an Oxford Handbook of Medical Emergencies. I think that's called a hematology section. Probably that will be more helpful for the internists. I think same question. Bleeding can cause not only reduced platelet count, but also raised. No, bleeding can cause raised platelet count, not low platelet count. But low platelet count, on the other hand, can cause bleeding. So it's the other way around. So if there's an active bleeding, the platelet count tends to be raised. But somebody with a low platelet count due to another condition will have bleeding, which is more susceptible to bleeding. So bleeding does not cause low platelet count. It's a low platelet count, which sort of makes the bleeding worse. Banded neutrophil bands. They are usually the blood film, so you will not get banded neutrophils on your report on the full blood count. But if the blood film reports say banded neutrophils seen, that means there is a slight left shift. Neutrophil production is slightly immature. Okay, you could see that in very non-specifically any condition, infections, sepsis, leukemia. So I don't think it's that important. It's important to make a diagnosis as a hematologist. For sort of the general, sort of the physicians, I don't think banded neutrophils are that important. And you will not get results from the full blood count.
Okay, I think
For
one last question, yeah. Just one last.
Okay, FRC path exam. I think there's a book called Postgraduate Hematology, but again, I think very much sort of the detail. Try to stick to lecture notes on hematology, which is pretty good, or essential hematology. I think these two books are pretty good. Sometimes the results came back with immature RBC, WBC without pathologist remarks. What should we do? Well, I think you ring the pathologist, or I think you look at the scenario, the algorithm, and try to work it out. And if there are still abnormal, so immature red blood cells and white blood cells, I think you should discuss with the hematology. That might be due to primary bone marrow disorder. So I think I am going to stop here. I think I hope you find it interesting, and any comments from the panel as well.
Thank you very much, Dr. Thin Maung. Thank you very much for your extensive presentation, which will be useful for everyday frontline doctors, either in hospital or in general practice. That's useful to me everyday GP the presentation or the recording or ဆရာဟင်းကုတ်ကိုလည်းပြောလိုက်ပါဘယ်မှာရှာလို့ရမလဲဆိုတော့
ဟုတ်ကဲ့ပါမြန်မာ GP Education Facebook page ကနေပြီးတော့မှကျွန်တော်တို့ launch လုပ်ပေးပါမယ်ဆရာ
Okay. Okay. Okay, thank you. Okay, thank you. Bye.